All right, so let's get started. Welcome, everybody, and welcome to those who are online. We're here in person. This is the first lunch in-person event the center has run since 2020, so I'm really super glad to be here. My name is Gordon Hull. I'm the director of the Ethics Center here at UNC Charlotte. And today we're here to welcome Anna Iltis, who is a professor of philosophy and director for the Center of Bioethics, Health, and Society at Wake Forest University. This will be the first in a probable series of 4 events on ethical issues in transplantation. A bunch of those are sort of bubbling up to the surface, so we hope to see you for the remaining 3. There'll be another one this semester and then 2 in the spring. We'll have materials out about those really soon. So now I don't want to take away from Anna's time, so here she is.
Yeah. Thank you so much. It's great to be here. Thanks for joining me, and I welcome your comments and your questions at the end. I really look forward to having some time for discussion, so I've made a point to save some time for that. So before I get started, the usual, I have to tell you this: there's funding behind some of this research, NIH funding, but I have no conflicts of interest to disclose. And I also want to acknowledge, and they're named and cited later as appropriate, but a lot of this is work that's based on work that I've done with other people in collaboration with them. And so I just want to acknowledge that this is not just all my work and my own ideas. So I'll begin with some background. Oops, too far. I'll begin with some background on what I've called, or we're calling, race-targeted genetic testing, and then look at some current practices and research that's going on with race-targeted genetic testing in the kidney transplant world, and talk about some of the ethical and policy questions that it raises, and then leave time for discussion. So race-targeted genetic testing, we're defining as genetic testing that is offered based on self or other identified race or ethnicity because of presumed genetic differences among groups. And this sort of self-identified or other identified is really important for those of you who kind of work in the world of race and health. You know that's one of the really big issues is people are labeling people, and it's like, well, how did that label even come to be? And it's not always clear who decided that this person was or wasn't a part of a particular group. So this is what we are calling race-targeted genetic testing, or RTGT. So how did we get here? How did we end up having race-targeted genetic testing in the first place? I think some of it certainly has to do with the history of race and racism and racial categories, and the development, the emergence of racial categories, right? The decision to even call these, to have people in groups and to call them different things, and to make distinctions based on various kinds of features. And some of it has to do with geographical ancestry. So there are gene variants that are sometimes associated with geographical ancestry, alleles that are much more prevalent in particular geographical areas than in others. And lots of us don't know our geographical ancestry. We might know my parents are from, but we don't know our sort of geographical ancestry and the kind of the ways that are of interest to geneticists. And so race and ethnicity have ended up being used as poor surrogates for geographical ancestry. And I think that is certainly true with genetic testing that is targeting Black or African Americans. So it's a poor surrogate. People keep saying this in health and healthcare and in the biomedical research world, and yet we keep on using it, which raises all kinds of interesting questions. There's lots of scientists and scholars who have argued against the use of race and racial categories in medicine and in genetics. There's all sorts of good reasons to be worried about this. It is a poor surrogate for geographical ancestry. Races are socially constructed categories. They are not discrete genetic categories. And so that as such makes them a poor basis for categories that are used in scientific research. There's a lot of genetic variation among racial groups. So once you start identifying groups, there's tremendous amounts of variation among groups, which in itself raises serious questions about why we think these groups matter and are helpful scientifically. Race, as I said earlier, is used as a surrogate for geographical ancestry, but it is not the same thing as geographical ancestry. And that has lots of implications. It sometimes means that people who are grouped together but don't actually share geographical ancestry, and this is going to be important for the sort of APOL1 and kidney transplant context later, people who are assumed to be part of the same group are treated as if they have the same geographical ancestry when in fact they don't. So in the APOL1 context, you'll hear me talk about, Western African ancestry versus other areas, and yet that's not a distinction that gets made once we start talking about race rather than geographical ancestry. All of that said, this can result in harm to patients and in poor research. So we're relying on sort of not very helpful categories to guide our scientific research and to guide health and healthcare in many cases for people who've been following kind of all the controversies about the use of race in various aspects of medicine, including kidney health. And it means that people sometimes who should be offered genetic testing are not, because they are presumed to not be part of the relevant group. It means that sometimes people who should not be offered testing, in the sense that they are not at increased risk for having the relevant gene variants, are getting unnecessary testing and unnecessary interventions. So all of that it raises some really serious concerns, and including ethical and policy concerns. I do want to note that there are scholars who have said, not so fast. There are important reasons for using race and racial categories in some ways, and ethnic categories in some ways in biomedical research. And so it's sort of, some people are saying, yes, there's lots of trouble, but it's too soon to just simply say, throw it all away. There are important issues here. And some of that has to do with research on social determinants of health and other kinds of things. So there are people who have really advocated for the judicious use of race and racial categories. And I think that's important to acknowledge. I've given you some examples here of either past or current areas in which there's race-targeted genetic testing, which, remember, is testing targeted at people because they are part of or presumed to be part of a member of a racial or an ethnic group. Some of these are probably really familiar. Certainly the history of sickle disease and sickle cell trait testing was historically connected to Black or African American race. That has changed, but that was historically the case. Testing for cystic fibrosis for a long time was assumed to be a disease of European Americans, and other people were presumed to not have it. You can imagine how bad it is for a patient who has cystic fibrosis and goes undiagnosed and untested because somebody thinks, but these people, whatever that group is, don't get CF, right? Tay-Sachs disease, APOL1, which is what I'll spend much of my time today talking about. So this is a gene variant that is associated. There are certain gene variants of the APOL1 gene that are associated with increased risk of kidney disease, and open-angle glaucoma. So APOL1 and open-angle glaucoma are two conditions for which there are current studies going on that are race targeted, and both involve Black or African Americans. So I'll say a little bit more about APOL1. This is an example right now of a place where both there's clinical and research race-targeted genetic testing, and so I'll talk about both of those today. It's generated my broader interest in race-targeted genetic testing. So my work has largely been on APOL1 and kidney transplantation and health disparities. And because of my work there, I got interested in this broader question of where else are we doing race-targeted genetic testing, both in the clinical and the research setting. And so that was kind of the springboard for my interest in this. So there are two variants of the APOL1 gene that have been associated with an increased risk of kidney disease in individuals who have two copies of either of the variants. So you can have any combination of those two variants, and if you've got two copies, you are at increased risk of kidney disease. Importantly, most of the people who have those renal risk variants or kidney risk variants do not go on to develop kidney disease. So there is this big question of why is it that 4 out of 5 people who have the genotype that is at increased risk do not get kidney disease? There's this assumption that there must be some kind of second hit, some kind of thing that must happen, that you have to have the genotype and something else has to happen in order for you to develop kidney disease. There's lots of theories right now, lots of research going on to try to figure out what that second hit is, but it's not yet known. These renal risk variants are more prevalent in people with recent African ancestry, particularly West African ancestry, though some other areas as well. But that has been treated as the equivalent of saying that anyone who is Black or African American is at increased risk of having these two renal risk variants. That's the statistic that is currently typically cited, is that approximately 13% of African Americans have, why is this jumping ahead on me? That approximately 13% of African Americans have the two renal risk variants. It's also been found in people in Brazil, Jamaica, Barbados, Trinidad, Peru, Honduras, Belize, among other places. So it is not exclusively an issue of people who are considered African American or Black in the United States, and yet we often talk about it that way. as well as people who are in West Africa. In addition to the risk of increased kidney disease in people who have 2 copies of the renal risk variants, there has been some retrospective research that suggests that recipients of kidneys from a donor who had 2 renal risk variants are at increased risk for allograft failure. So even if the recipient does not have the 2 renal risk variants, if the kidney they received came from a donor who had those 2 renal risk variants, then their graft, their transplant is at an increased risk of failure. And there have been some case reports of this also looking at living donors, where the living donor had 2 renal risk variants, and the living donor then subsequent to donation had worse outcomes than would have been expected, and was more likely to develop kidney disease. So there's a lot of interest in understanding what happens to people who are donors, living kidney donors, who have 2 copies of the renal risk variant, and what happens to the recipients of those kidneys, and what happens to recipients of kidneys from deceased donors where the donor had 2 renal risk variants. So far, all the work that has been done has been retrospective, which, as you know, is never sort of the way that people wanted to really learn things. So now there is prospective research going on, and I'll talk more about that. But there's a great deal of interest in understanding the role of these APOL1 renal risk variants in kidney transplantation. And there's a lot of really important ways in which that ties into hopefully reducing issues of health disparities related to kidney health. And so I'm going to talk some more about that. So Apollo is this national observational study that this is the APOL1 long-term kidney transplantation outcomes consortium. You can imagine why we never use the full name. Apollo is the study that I'm involved in right now. And it is a national study. It's an observational study. So nobody's treatment is getting changed because they are in this trial. It's not a clinical trial. It's not a randomized trial. It's an observational study, but a prospective observational study looking at the at recipients of living and of kidneys from living and deceased donors who are expected to be at increased risk for having 2 renal risk variants of the APOL1 gene, which means looking at recipients of kidneys from donors who get identified as Black or African American when they are donors. It's also looking at living donors and outcomes for living donors, though the primary focus of Apollo at this point is really the outcomes from deceased kidney donors and the recipients of living kidney donors. There's a second study that's an ancillary study to Apollo, so it's a sort of related to Apollo, called LIDO, which is the Living Donor Extended Time Outcome Study. And that study is looking more at the implications of on long-term outcomes for living kidney donors. So they're looking back at kidney donors, people who donated a kidney a while ago. Because it's one thing to say, what are your outcomes in 2 years or 3 years? It's another thing to say, what are the outcomes in 5 and 10 and 15 years? So LIDO is doing that work. And I'll say more about all of this. But before I go on, I want to kind of contextualize this and say a bit more about health disparities in related to kidney health. Because it's important to kind of understand why the work that's going on with respect to the APOL1 gene and genetic testing is matters, and how this might fit. And it's certainly not the only piece. And I'll repeat that over and over again. It is not the only piece of health disparities related to kidneys. I think it's so important that we not sort of overly emphasize like it's all about genetics, right? It is not all about genetics. So you'll hear me say it again. This is not meant to be a comprehensive overview of health disparities related to kidney health. That's a whole other topic, but I want to kind of get some sort of big picture ideas on the table. So there are significant health disparities related to kidney health in multiple ways. African Americans are, compared to European Americans or white Americans, are at increased risk, 4 to 5 times increased risk of developing kidney disease and going into kidney failure. African Americans make up approximately 13% of the US population, but they are over 35% of the dialysis population, right? That is a very disproportionate number. And evidence of a significant health disparity. There's also significant disparities with respect to access to transplantation, and this has been documented sort of at every stage of being offered, told about transplantation, of getting listed for transplant, of receiving a kidney. So once people are on the transplant list, right, that means everybody's on the list needs a kidney. African Americans wait on average 1 more year than European Americans wait for a kidney, and they're more likely to die while on the waiting list. Transplant outcomes are also worse for African American or Black Americans. They are at increased risk for graft failure. Living donor outcomes also, there's evidence of health disparities there. So African American living donors are at increased risk of developing end-stage renal disease than non-Black or non-African American living kidney donors after they donate a kidney, right? So that's one of the big concerns when people donate a kidney is many people go on and do just fine with one kidney and some don't. And the question is why do some do fine and some not? And secondly, why is it that African American living kidney donors are overall faring worse? Which you can imagine sort of spirals into decreased access to living donor kidney transplantation, right? So if you've got a kidney donor who is likely to have worse outcomes, that is not somebody that a transplant program wants to use as a donor, right? Or that somebody is comfortable donating, right? If you know you're at increased risk of a bad outcome as a donor. And again, because I'm going to say a lot about genetics and kidneys, I just want to emphasize those disparities cannot possibly in every single way be explained by genetics. The genes are important, and I think they're important in certain kinds of ways, or we think they are, and that's why there's a lot of research going on, and that research could have some really important implications, but it is not the only reason that there are health disparities. And I think broadly speaking, when we talk about health disparities, there's often this temptation to be like, oh, if we could just find the gene, right? Then we have an explanation, and we sort of take our focus away from all of the other sorts of things that often get captured under the social determinants of health umbrella. Because those are much harder to talk about and to address, right, than genes. There's this sort of, I think often this, if we could just have a genetic explanation, then we'd feel so much better. And that's something that we've been really careful to avoid when we talk about the APOL1 gene, and yet it still is important, right? Genes do matter, it's just that they don't tell the whole story. So a little bit about the role of APOL1 genetic testing in kidney transplantation today. So I said there's a lot of research going on. I've mentioned some of that, and I'll say more about it. But APOL1 testing is being used in the clinical setting in the context of living donor kidney transplantation already. Current practice, though, varies widely. There are transplant programs that do not use APOL1 genetic testing at all. They don't tell potential donors about it. They simply do not do it. They do not offer it. There are programs that offer it. So they tell people about it and they give people the choice of whether to get tested or not. There are programs that require it. If they or the potential donor if somebody identifies the potential donor as Black or African American. So there's well-documented research that transplant programs have very disparate practices right now. So some people are not offered testing at all. Some people are offered, some people are required to undergo testing. We've also documented, we and some other groups have documented that there is variation in how transplant programs identify donor race. Are they using self-identified race? Are they using race that somebody in the office just checked a box? Often we don't know. They're not always able to tell you how they've identified donor race, but that has some really significant implications. We don't know who is deciding who counts as somebody who gets tested. And by the way, in programs that are offering it, it is offered based on race. It's not sort of offered to all potential donors. It's offered to people who are deemed to be at increased risk of having the 2 renal risk variants, i.e. people who are identified as Black or African American. There's a lot of variation among how decisions about testing get made and discussed, whether genetic counseling is offered in the context of testing or not. There are variations in how and whether the results of a genetic test are shared. So I know of people who have said that they sort of, as a matter of routine matter, do APOL1 genetic testing on Black or African American potential donors, and they don't necessarily even talk about it. It's just part of the routine battery of tests, and they might not even report back the results to an individual. They might not even end up giving them their results, right? If there's other reasons why they can't donate, they might never even talk about APOL1. And then there's also variation in how the genotype, so how the test results affect donation. So if a person comes back and has 0 or 1 of the renal risk variants, then there's no worry, right? That would not be an exclusion basis for exclusion from donation. But if they have 2 renal risk variants, then what happens? So some programs will automatically exclude a living donor. Some programs will discuss it with a living donor. And in many cases, that idea of increased risk, both for the donor and potentially for the recipient, mean people don't end up donating. And in some cases, programs will allow living donors who have the APOL1, 2 risk variants to donate if they're over a certain age. You might think that sounds weird, right? You'd think, well, wouldn't it be better if they were younger? Well, here's the idea. So remember I said only 4 out of 5 people who have the 2 renal risk variants do not develop kidney disease. So the idea is if you've made it to a certain age and still have not developed kidney disease and have this genotype, you are probably not among the people who's going to get kidney disease because you have the APOL1 renal risk variants. Most of those people are developing it before a certain point. So it's kind of counterintuitive. I remember when I first learned that, I thought, well, that's kind of strange. And then it made perfect sense, right? If most people who have the renal risk variants are developing kidney disease by a certain age, once you've passed a certain threshold, it's like, we don't know why, but you now no longer seem to be in the at-risk category. Of course, if we could figure out what the second hit is, then you'd kind of have a better sense of all of that. But again, all of this is different from program to program, transplant program to transplant program. And patients who are going through the transplant process and potential donors who are going through the transplant process don't necessarily know this, right? You go to the program you go to, and unless for some reason you have access to information from other places, and certainly now many more people do because of the internet and because there are many more networks. But the reality is people are not necessarily even being told that there is this variation. So variation in all of these different ways has been well documented, and it is being used in the living donor transplant context. And I think it's being, from what people tell me, so this is anecdotal, it's being used increasingly more in the living donor context. So maybe programs that didn't use it 3 years ago might be using it now. Certainly there are patients who know about this and are starting to ask about it. It is not currently used in the deceased donor context. That's part of what's under investigation in Apollo. But what is used in the living donor context right now is donor race. So when a kidney is offered for transplant, it is evaluated. And there are a whole bunch of metrics that go into what's called the KDRI, or the Kidney Donor Risk Index. And I'm not going to get into the complexities of that because I would probably mess it up. And it's not really relevant for what we're talking about. But what I will say is that one of the metrics that gets used is donor race, and that is Black or not Black. Is what that sort of metric is. And the reason that that's been included in the KDRI is because kidneys transplanted from Black or African-American donors are at a 20% increased risk of graft failure or allograft loss. So they are 20% more likely to not work as a transplant over time. And the reasons for that are unclear. But because of the association between having 2 renal risk variants from the APOL1 gene and an increased risk of kidney disease, and this retrospective research that has shown that kidneys donated from donors who had the 2 renal risk variants failed at a higher rate, there is some thinking that at least the hypothesis is that maybe the reason that overall there's this 20% higher risk of allograft loss can be explained by the 2 donors having the 2 renal risk variants. And so there's this question now, which is, should you keep using race in the KDRI, or could you, depending on what the data show, replace race with APOL1 testing and then actually know which kidneys are at increased risk and which are not? So that's the hypothesis. That's why this research is currently being done. We don't know the answer right now. Some have argued that you should just take race out of the KDRI right now. And then there's other people who are saying, let's wait and see what the data show. So we'll see where all of this goes, right? The Apollo data are not in, the LIDO data are not in, but this is why the research is being done. So if all of this if the hypothesis pans out and it turns out that you can explain the increased risk of allograft loss because of the genotype, because of an APOL1 genotype, you can probably, hopefully, lower the rate of the kidneys that get discarded. right? So this is a huge problem in transplantation, that lots of kidneys that get donated or available for or offered for transplant are in the end not transplanted because they're deemed not sufficiently good quality or other concerns. And so that's part of what's at stake. And if you can increase the number of kidneys that are available for transplantation because you lower the discard rate, you have more kidneys available for transplant. And if you take out only the kidneys that are in fact more likely to fail, you should, in theory, have better overall outcomes from transplant. So that's part of the hope, that this could contribute to improved outcomes and reduced disparities in kidney health related to transplant. So Apollo and Lido are both NIH-funded studies. They are underway. They're designed to improve sort of our understanding of the relationship between APOL1 genotype and transplant outcomes, both for recipients and for living donors. The retrospective studies that have been done have found that approximately 15% of Black kidney donors have 2 APOL1 risk variants. And so that's important to know. It's not the vast majority of kidney donors. And yet right now, all kidneys are treated as Black or non-Black kidneys. And so the question is, could you, if the data turn out to show what the retrospective data have shown, research has shown, that having the 2 APOL1 risk variants increases the risk of graft loss in recipients, then you may have some new way of evaluating kidney, the quality of kidneys that are donated, rather than what we do now, which is to use race in the Kidney Donor Research Index. And Apollo is also looking at living donor outcomes, but Lido is designed to study those outcomes over a longer period of time. So they are going back to people who donated between 2001 and 2005 and looking at their outcomes and their recipients' outcomes. So that will help us have more long-term data, which is really important if you are trying to evaluate people's health over the long term, because most of us don't care only how we're going to be doing in 2 or 3 years, right? If you were going to consider donating a kidney, you're probably going to wonder not just what might happen to me in 2 or 3 years, but how am I going to be in 10 years? So that's really important work that is currently going on. I want to say a bit more about the current use of APOL1 in the living donor context and the future use of APOL1 testing in that context, because I think this is an area that raises some really important policy and ethical kinds of questions. Some of my colleagues and I worked on this paper a while back, kind of saying, look, what are the real ethical questions here that we need to take seriously and we need to think about, and that programs need to think about as they approach the possible use of APOL1 testing or as they evaluate their current use, and what should we be doing going forward. So the first is just who should be tested, right? Who should be offered APOL1 testing, or who should be assumed to require APOL1 genetic testing? Those are all really big questions, but race right now is being used as a proxy. And as I said earlier, sometimes it's self-identified race, sometimes it's other identified race. And that means that there may be underuse and overuse of APOL1 genetic testing. So people who are not appropriate candidates for testing are required to undergo testing. People who could benefit from testing are not getting it. So that's a really big question. A second question is should testing be offered? Should it be required? Should it be encouraged? Should people have a choice? Should you say, if you want to be a donor, you have to get this test? What should that look like? Who should decide and how? What information should patients get when they are asked to consent to this testing? What's the relevant information that they need? And there are a lot of people who have real concerns about undergoing genetic testing for all kinds of reasons, including, for example, they might face genetic discrimination later on. And that there may be implications for their families of having these results. So what information do people need in order to consent to testing? And many people if it's a part of a package deal, they may not even realize that, which tests they're having and which ones they're not having done. How should results be used? So part of this is, how do you use the results in evaluating the living donor? If you have 2 APOL1 risk variants, does that mean you can't be a donor? Does it mean you can be, but we should talk about it? Does it mean you can be if you're over a certain age? Does it mean it's over? See you later? We don't know, right? Those are really big ethical questions that right now are being decided at the transplant program level, and I think are really serious questions. They have lots of implications. A second sort of related issue is, in terms of how it should be used in the living donor context is who should have access to the results, right? Because if it turns out that this has implications not only for the living donor, but for the recipient, is this information the recipient should be able to have, right? We're not used to saying your genetic information has to be shared with somebody else as part of their healthcare. And yet you can imagine why a recipient might say, I want to know this, right? I want to know. And by the way, just in the deceased donor context, people are not allowed to be told the race of their donor, just which is, and so in the deceased donor context, you are not allowed to know. Now, should families make contact later through an organ procurement organization, that may eventually be known, but that is not something that is disclosed. In fact, it's prohibited to disclose donor race in the context of deceased donor transplant. So I just want to make sure people know that. But you can imagine why, if somebody's reading data that say, hey, kidneys from African-American donors are at a 20% increase of allograft loss, you can imagine why a potential recipient might find that information relevant in the deceased donor context. And in the living donor context, they might decide, I want to know the APOL1 results, in part out of concern for themselves, but quite frankly, perhaps even more so out of concern for the donor. Who wants to accept a kidney from somebody who is at increased risk of having harm themselves because they donated and did something for you, right? It's complex. These are big ethical questions. And how should the test results be shared? Is this something that should always involve a genetic counselor? Do the physicians and nurses disclosing these results need specialized training? Like, how should you do this? Who should be talking to whom and why? And right now, the practice varies tremendously. As many people know, there are not enough genetic counselors to go around for all the ways in which genetic information is being used in healthcare and in biomedical research. So in many, many cases, people are getting this information without the help of a genetic counselor. We're not even sure what that would look like or what that should involve, because this is all very much emerging, but nevertheless, those are really important questions. And so to help try to answer some of these questions, part of our current work is doing a lot of stakeholder and community engagement around these issues. And we've done it through different sorts of methods. And I want to talk a little bit about something that's currently happening, which is the Delphi panel. So Delphi panels, for those of you who are not familiar with them, are these sort of, you kind of do these rounds of consensus building with the same set of participants. And they're a really interesting way to kind of get at conclusions about sort of what are the views of people about how we should proceed with something. And they're used in all different kinds of contexts, certainly not just in the bioethics world. But they provide a really interesting way of getting diverse stakeholders to address issues that, where there may be conflict but decisions have to be made, and to say, how do diverse stakeholders understand and come together to talk about these kinds of things? So we want this Delphi panel to be informed by the kind of scientific evidence, both the existing evidence and the emerging evidence, but we also want the kind of judgments of this panel to be informed by what's already known about the perspectives of stakeholders. So some of that is information that we have gathered, and some of that is information that has been gathered already about race-based or race-targeted genetic testing. And so, because we wanted to make sure that this panel was working with sort of as much information as possible about people's views about the use of race-targeted genetic testing, where APOL1 testing is an example of that kind of work. And so this question of, all right, well, what else do we know about race-targeted genetic testing led us to conduct a systematic review of the literature that has been done, on race-targeted genetic testing. Because as I said earlier, there are other disorders and conditions where it has been used in the past. And so to help inform our Delphi panel, we ended up doing the systematic literature review and looked at reports of research or community engaged projects that examined how people who identify or are identified as, and this, I keep coming back to this issue of self versus other identified because it's really important. So how people who are identified as or identify themselves as Black or African-American perceive genetic testing that is that presumes some genetic difference and that targets people of that racial category because there's an assumption of difference within that group. So these are examples of genetic testing that has used race in many cases as a surrogate for geographical ancestry. In the literature, we found reports of studies and community engaged projects looking at, not surprisingly, APOL1 testing, but also cardiovascular disease, glaucoma, smoking and tobacco use, sickle cell disease and sickle cell trait, a variety of forms of cancer, and with especially prostate cancer and breast cancer, along with several others. So we found examples of either research or clinical stuff that was happening with respect to all of those conditions that involve race-targeted genetic testing of people who are Black or African American. Almost half of the publications that we reviewed did not specify how they had identified the race of their participants. So it is considered best practice now in reporting biomedical research to do that, to say if you're using racial categories to explain how racial categories were, how people were categorized, but about half the publications did not say that. Of those that did, most say that they relied on self-report, and 2 or 3 said that they relied on the medical record, but we don't know how that information got into the medical record in the first place. So again, there's a lot that's not known about how race and racial categories are being used and how people are being classified. And then the sort of meat of the project was to look at these publications and to say, what contributed to positive attitudes towards race-targeted genetic testing and what contributed to negative attitudes. And so I'll say at the outset, it was not all bad, right? People did not automatically think that any use of race was a bad thing. So I'll say more about what we found. So we called facilitators factors that contributed to a positive attitude towards race-targeted genetic testing. And we found 4 very broad categories of things that make people say, in some sense, race-targeted genetic testing was a positive thing. So these were personal control, individual level benefit, population or community level benefit, and communication. So with personal control, people wanted to be able to control whether they underwent genetic testing or not. So if people who were sort of offered, or there was some context in which race-targeted genetic testing was on offer, people felt more positive about it if they could themselves decide whether or not to get tested. So for example, for the APOL1 context, it's the living donor gets to decide whether the living donor gets tested, not sort of somebody deciding that you have to get tested. Many studies found that individuals who thought that they might benefit personally from undergoing the testing were more inclined to view the testing favorably. I mean, that's not at all surprising, right? So this was true whether the race-targeted genetic testing was being done in the clinical or in the research setting. So in both contexts, people said, if I think there's some personal benefit to having that information, then I'm much more likely to be favorably inclined to it. Another really important facilitator was the perception that this kind of testing might benefit a community or a population. So among the possible benefits were helping to explain or illuminate existing health disparities. And some people reported that finding genetic differences was actually would be a good thing because it might destigmatize, right? The assumption that certain health outcomes are always associated with behavior. A number of people said, actually, I think it'd be great if we could find a genetic explanation for this, and it would destigmatize a population that is assumed to have poor health outcomes because of behavior or other sort of social lifestyle choices. In some cases, race-targeted genetic testing was seen as a welcome kind of indication that someone was paying attention to the health of Black people, and that it could improve the health of Black people in the future. And there was this perception that if this testing is actually good for reducing health disparities and improving health, then people were more favorably inclined to it, right? And some people said, look, it sounds to me like you're finally paying attention to health disparities. And finally, there was a lot of sort of information around communication and the kinds of information that people needed, the communication practices that people found helpful and useful. So providing the kind of information that people needed transparently, addressing fears, having information provided by people who were trusted, all of those things contributed to a more favorable sort of outlook on race-targeted genetic testing. So like I said, it was not all negative. I think a lot of people, when I was kind of surprised by that myself, I thought surely people are going to be, when you start asking people about this sounds like a negative thing, right? You're targeting people based on their race. And it was not all negative. So there were some facilitators, but there were a lot of concerns that we found also. So barriers is what we've called those, factors that are associated with a negative view or concerns about race-targeted genetic testing. And I think these will not be terribly surprising. So kind of the converse of the facilitators, where people did not perceive a personal benefit to getting tested, they just were less likely to think that this was a good idea. Second, there were a lot of concerns in the literature about the burdens of getting tested, such as the time that was required, making somebody go to a specialist, or go to another visit somewhere else, go to a different place. The costs that could be associated with both going to another place, but also with the testing itself. There are lots of questions about who's paying for all this stuff. Concerns about having to give blood, about how much blood was going to be used. All of those sort of led to some concerns about race-targeted genetic testing. And some of those might lead to concerns about any genetic testing, right? Not just race-targeted testing. A third concern, not surprisingly, was the concern about confidentiality, right? Who's going to have the test results? What's going to happen to them? What's going to happen to my data? The potential harmful impact of test results. So could test results lead to cases of misuse? Might I be discriminated against? Could I experience psychological harm from fear, for example, that I'm now at increased risk? And there were real concerns in the APOL1 context about limiting access to living donor kidney transplantation. So there's already a disparity in access to a living donor kidney between African American or Black Americans and European Americans. And the worry was that if you start doing this, you're now going to exclude even more living donors, and that could harm the people who are waiting for transplantation. Fifth, again, not surprising, concerns about trust, right? Mistrust of the healthcare system or of scientists led to unfavorable views regarding race-targeted genetic testing, including concerns about how much blood samples might be used in the future. The conflation of race and genetic ancestry and culture, and the resulting lack of clarity about who exactly is at increased risk of particular conditions, was a concern. There were some really nuanced views that came out in the literature of people who said, no, wait a minute, how are you deciding who counts, and how are you understanding these things? So there was a lot of, I thought, very rich work that came out of just community engaged projects and research with lay people. These were not academics by and large, raising these really important kinds of questions and issues. Seventh, there were all kinds of barriers or all kinds of concerns related to the lack of open and clear communication. These included kind of secrecy within families about diseases, reluctance to talk about diseases, and certainly reluctance to talk about diseases in the broader community. There was also poor communication or concern with poor communication by physicians, people not explaining things, as well as kind of a perceived need for more kind of health education in general, and health literacy, concerns about health literacy, and people finally really wanting to know, what does it mean for me, right? Statistics about 20% this or 15% that are all well and good, but most of us in the end want to know, what does it mean for me? And in the context of research, often the answer is, we don't know. Right? We don't know, and we can't know. And if you try to tell somebody as act as if you do know, it's not helpful, right? Because it might not be accurate information. So for a lot of people, the perception that you could still do all this testing and you still can't tell me what it means for me was a concern. And that, by the way, is true of lots of genetic testing, right? Even when these tests are well validated and everybody knows what they mean, it's often hard to tell you, but you're going to be one of the people who does or does not, which is part of why genetic research needs to be sort of encompass much more than just the genetic components of health, right? And there's a lot of discussion of that today. Interestingly, we did not set out to find research that was specifically about clinicians' concerns with the use of race or attitudes towards race-targeted genetic testing, but some of the publications and the projects that we found did in fact engage clinicians. And so in that context, several concerns came out. There were a number of studies where clinicians reported that they were personally concerned about doing race-targeted genetic testing, that they thought it was inappropriate to target people based on race, and that they were concerned about doing that. They were concerned about discrimination against minorities, and some of them were concerned about their own understanding of genetics and ability to kind of communicate about genetic information. And that is something that I have seen in lots of other places as well, where sort of typical clinicians are saying, there's a lot of information being used these days about genetics, and I don't feel like I'm confident in my ability to understand and certainly to explain it. So that was another one of the concerns that clinicians raised about sort of using this testing, when they said, what am I supposed to say, right? I don't really know what to say. So as we gather more evidence about APOL1 renal risk variants and their role in transplant outcomes for both living donors and for the recipients of living and deceased, of kidneys from living and deceased donors, transplant programs and policymakers are going to need to continue making decisions about whether and how to use APOL1 testing. And so our hope is that some of the research that we're doing will help inform those decisions, to make them informed not just by the scientific evidence, but by the sort of psychosocial and other kinds of ethical concerns that people bring to the table and preferences that people bring. I think the discussion in all of this makes really clear the importance of stakeholders' views. Stakeholders have really nuanced views about race-targeted genetic testing. It's not so simple as to say they're positive or they're negative. We did not find all or nothing thinking about race-targeted genetic testing. And I think that was in some sense surprising and in some sense really important. It was really important to kind of find those facilitators and barriers. So we really hope that the kind of evidence that we're collecting through our Delphi panel, through these other kinds of processes, and that other people are engaged in research that's also contributing to this, will inform policymakers and transplant programs as they make future decisions about how to use APOL1 testing. The other thing I really want to say is that this sort of work involves lots of ethical questions and lots of ethical issues. And I think throughout the entire course of it, as decisions are made, as studies are designed, all of it requires really robust community engagement. And so one of the most rewarding parts of my involvement in the Apollo study has been my very close work with the Community Advisory Council. So the Community Advisory Council consists of a group of self-identified African-American and Black individuals who are closely connected to issues of kidney transplantation. So these may be kidney recipients of living and deceased, of kidneys from living and deceased donors. In some cases, they are living donors. In some cases, they are living donors who then became kidney recipients, right? People who ended up with a bad outcome. Which they might or might not have had anyway, we don't know, as well as people who are on dialysis and so people who are very closely connected to the kidney transplant and dialysis world. And the members of this group have participated in Apollo from the very beginning. So they were involved in the study design, in pretty substantially rewriting the consent form. We developed patient education materials, sort of infographics that are made available to all potential participants to kind of explain, okay, what are we talking about when we talk about the APOL1 gene? How does the research work? Lots of sort of public facing kinds of work. The Community Advisory Council participates in all the big biannual, like twice a year, all of the investigators across the country who are involved in Apollo meet, and the Community Advisory Council is part of that. We have a monthly conference call. We can sort of members of the Community Advisory Council are on lots of the subcommittees of the grant, working on all different kinds of things. And earlier this year, the Community Advisory Council and I published a paper in the American Journal of Kidney Disease on kind of the role that they have played in the study and the kind of importance of similar roles in other studies, especially that involve issues of race and ethnicity. So that has been a really rewarding part of all of this, is to have this really robust community engagement that has not just been about sort of every now and then investigators will check in and say, what do you think? I mean, this group has been a part of all of this from the beginning, to the point that last year we published a paper, and everyone was quite surprised that when you're on a big grant, you have to go through this whole process to like have your work vetted and all this kind of stuff. But we now have a paper in the American Journal of Kidney Disease, and I think that was very exciting for the Community Advisory Council to publish, not sort of just in a lay kind of context, but to publish in a nephrology journal. I think it's so important to situate this, and I'll close with this, and I really want to open this up for discussion. It is really important to kind of situate all of this in the context of kidney health disparities, and to recognize that this is one small piece of that, but I think it has the potential to be a really important piece. So kidney transplantation becomes necessary only because there's kidney failure, and it would be fabulous if you could stop that problem, right? And yet, it's real, and this may help improve, reduce health disparities related to kidney health in a number of ways. So if you can increase the number of kidneys that are available for transplant overall, if you can ensure that the people who are donating kidneys as living donors are well informed and able to make decisions about their own health and safety, if you can increase the number of people who are suitable living donors, because you can identify who is most at risk for having a bad outcome. You can help living kidney donors and their recipients. So there's a lot of work that could be done here that could good that could come of the work that is being done here. It's really important that this work be done kind of in the context of other issues related to the social determinants of health. And that is something that people are really aware of. But improvements in kidney transplant outcomes could have a really significant effect on reducing kidney health disparities in general. There's certainly other pieces of it, but this work has some real promise. And of course, we don't know the answer yet, right? We're waiting on the results. We're not done. And so we'll see. But that's kind of where the research came from, and that's where we think it might be going. And I'm going to stop there. And I really look forward to your comments and questions, but not just questions. I welcome you to sort of kind of engage in a discussion as well. So thanks so much for your attention. Go ahead.
Has anybody done any studies that like determine the accuracy of self-identified categories?
Yeah, it's interesting. So what would it be to be accurate?
Yeah.
Right. If these are socially constructed categories, what does it mean for it to be accurate? I think I don't know. I don't know the answer to that question, but I'm as you ask it, I'm thinking, the philosopher in me is going, well, what's the accuracy, right? What does it mean for it to be accurate? There have been studies comparing self versus other identified race, right? About how often that, and I don't know the answers, but I know that work has been done, looking at what happens when you compare what people call themselves versus what somebody else classifies them at. That work has been done, and it's interesting because it's not perfect, right? But the question of what would it be for it to be accurate is a really interesting one. I think a different question that also would be really important to study is how closely does self-identified race or ethnicity align with geographical ancestry. And of course, we don't have perfect data on what that would look like, right? As anybody who's done, ancestry.com and stuff. I have never sent in a sample to any such site, by the way, but I know people who have, and they're always shocked. They're like, wait, now their percentages are changing over time. How does that work? So it's really hard to know what it would even mean for any of that to be accurate, but it's an important question. So thanks.
Yeah, and then if no one else has a question, there's a statistic you mentioned, 20% risk of graft loss with the 2 risk factors, correct?
No, so the 20% was just overall. We don't know if it's from having the renal risk variant or not. We just know that on average, kidneys transplanted from donors who are Black are at 20% increased risk of not functioning raters. So those recipients are at 20% increased risk of allograft loss. One of the questions that Apollo will hopefully answer is whether that's explained by APOL1 genotype, or some of that is explained by APOL1 genotype. So right now, we don't know what that number is. Based on genetics, we just know that people who are listed as Black as donors, when those kidneys get transplanted, there's a 20% higher chance of allograft loss. And the question all along has been, why? Right? And the thinking is that it's possible that APOL1 genotype explains some of that, probably not all. Yeah, go ahead. I think there was a question in the back. And then up here. I think they want you to use the mic, so just hang on for a moment.
Yeah, thank you very much for your presentation. I have a question about the community engagement. How do you, what are the metrics that you evaluate the success of your community engagement? And
that we evaluate the success? That's a great question. It's a great question. I think there's actually a lot of debate about what is good community engagement. And there is a lot of literature on what's effective and what is not effective. So we have tried to be as kind of evidence informed as we can be in designing our processes. I think one of the signs of success is the evidence that we are able to show that in fact the Community Advisory Council has had an impact on how the study is conducted and what is being done and the materials that are distributed. So it's not just sort of they've rubber stamped things, right? It's to me that's a great mark of success. Like there was this and then there was that. And that change happened because of the Community Advisory Council's involvement. I think some of it also has to be kind of people's perception of how welcome they were and how their own input was sort of acted upon and received. So I think that's another important piece of it. But I think for me, one of the big things has been things have changed, right? The Community Advisory Council has had an effect, a positive effect, I would say, on the study, and the investigators routinely ask for that input. So that's, I think, another piece of it, is not sort of, we don't have to keep knocking on the door, right? People have welcomed that. People have solicited input from the Community Advisory Council. When people are doing ancillary studies, they come to the Community Advisory Council and say, here's what we're planning to do, talk to us. So I think that's another mark of success, is that it's been welcome.
Just adding on top of that, did you run any experiment to just measure that, or no? It's, I mean, that your
No, I mean, it's,
understandings.
I wouldn't say we did experiments to measure it. I mean, we kept track of things that we did. So we know what we have all of the minutes from every single meeting, that we've ever had. And we have the evidence of, there was this consent form, and then there was this proposal about how to return research results. And then the Community Advisory Council's input changed it. And there, so there's lots of places along the way. And we give some of those examples in our paper. But yeah, thank you. Go ahead.
My question is also about the Community Advisory Council. I'm curious how you selected people for that.
Ah, great question.
So I know you said it's all Black people that have had some involvement with kidney donorship in the past. So I'm curious how you tried to select for some amount of diversity, or are people being compensated for that? Just curious.
Okay,
about
great. So I'll just answer on the compensation question. So for our monthly conference calls, we do not have compensation available, but when we have this, we have twice a year, we have kind of an all-day meeting with all of the investigators from all of the sites all over the United States, and people are compensated to participate in that meeting. It used to be in person. We met back in 2020, and then we have met now on WebEx or Zoom for the time, but they are compensated, and they're compensated at the same rate that NIH pays. If you are a reviewer on NIH grants, you get paid it's a very modest fee, but you get paid for all of the review work and for showing up to the meeting. And so we just said, we'll just use the same NIH rate. So they are getting paid the same as somebody who's reviewing a grant for NIH on a review panel. In terms of how they were selected, so the NIDDK, which is the National Institute of Diseases of Digestive and Kidney Disease, it sort of decided how that would work. And what they did was, there are 13 clinical centers throughout the United States that are kind of leading the study. And then each of those clinical centers has a bunch of centers, transplant programs kind of working under it. And so NIDDK asked each of the 13 centers to nominate 2 people. And so we have geographical diversity because of that. So we've got people all over the country because of that. And we also explicitly sought out not just one category, so not just living donors or not just recipients, or we wanted a breadth of experiences, including everything from I'm on dialysis, I'm waiting, I've received a transplant, I gave a kidney, that kind of thing. So so that's how we kind of achieve that. I don't know that there's ever a perfect system, but we definitely have geographical and experiential diversity.
Yeah, thanks for your talk. So I wanted to ask about you kept saying that the genes may be only a small part of the story. So I guess I wanted to ask more about that. And this is kind of I'm asking for your take on my kind of cynical take, right? So sure, the genes are probably a small part of the story, but they're getting a disproportionate amount of the NIH funding. So I guess I look at the massive health disparities, and then I heard the stuff about it's only a subset of African Americans that have the variant. It's only a small subset of people with the variants that have problems. So how much is this going to move the needle? I guess we don't know the exact answer, but shouldn't the money be going towards social determinants of health instead of Ebola?
This is always the question of how biomedical research gets funded and what research gets done, right? Yeah, I mean, there certainly are people who talk about that, and that's in all kinds of contexts. It's not just in kidney health that people will say that. And of course, you go where the money is. And so it's questions about sort of how decisions are made about what kinds of research gets done and what research gets funded. I do think that there is a really significant potential for this to have an impact, in part because of the trickle-down effect, right? So it's not just, oh, you could improve the outcomes of living donors and all recipients of kidneys, but who knows if some of this is also, there's also a lot of information, a lot of research going on and trying to understand the disparate impact of genotype on outcomes. Why is it that all these people with the same genotype, only some get kidney disease? Because if you can answer that question, you may be able to prevent kidney disease in all of those people, right? That would actually be fantastic. And so it may not only contribute to the transplant piece. So this is hopefully producing information that will be used in other kinds of ways. But the big issue will be, how do you integrate this with issues of social determinants of health? So part of what's coming out in some of the Community Advisory Council discussions is how this needs to be done in the broader context. And I think that will kind of affect further work that gets done, because people are talking about all the pieces that are tied to kidney health that are not just the genetic piece. And a lot of that is coming out in our discussions. And I think a lot of investigators certainly appreciate that. And the question will be, can you get the NIH level funding to sort of connect those dots? And I mean, my own, again, this is just purely my own opinion and my own kind of anecdotal experience, that people are ever more appreciating that. And now it's like, okay, how do you piece that together? And people are, I think today more than ever, serious about finding ways to do that. And the fact that there are all kinds of us collaborating on these grants who are not physicians and scientists, I think bodes well for that. I mean, I am funded on this project. It's not just sort of, I show up out of the goodness of my heart. I love what I do, but I'm actually getting, there's part of my salary is covered by this, and that's positive. Not just for me personally. I mean, the idea that people are appreciating the need to expand the disciplinary engagement of people in this research, I think is an important step. But you are absolutely right that there are big questions about what research do we do? How does it get funded and all of that?
What regulatory agency of the federal government oversees genetic testing in the biomedical context?
So in this case, it's NIH, because it's so NIH oversees the study, and genetic tests, I believe, are under the purview of the FDA. So the test that's being used here is an approved test. It is a test that's already done, like I said, in the clinical setting, and it's all being done in labs, in the same labs that are used for clinical testing. So there's nothing experimental about the testing that's happening in this context. So we are under the purview of the NIH. So we have to adhere to the common rule and to the NIH's sort of subparts of the common rule. And I guess I think it's FDA has oversight over the test itself. But like I said, it's an approved test, and it's being done in what are called CLIA labs. So the labs that are certified for clinical use. So that there's nothing experimental about the test.
So to follow up on kind of policy, I was wondering if you kind of know the general kind of landscape of where the policy is. I mean, you just did mention that it might be like under common rule. So like policy around the fact that it's required in some places, and then also like who holds these, like who owns these results, and what are they allowed to do with it?
Yeah, so there's different issues. So the NIH is we're under the purview of the NIH for the study. What's happening in transplant programs in terms of the living donor context is a totally different thing, because that's not research. That's just transplant programs are doing it. And right now there's not a standard of practice, because there's not the evidence base to have a standard of practice. My expectation is that at some point you will have enough evidence that there will be recommendations and standards established. And so in terms of the sort of kidney allocation systems, like all of those policies that get established at the national level, I think when there is more evidence and more data, eventually they will work on having standardized practices. So my own expectation is not that it will continue to just be every program is doing kind of its own thing. But the reality is that right now there are no practice guidelines, because there's not the evidence base for them. And so I expect that over time that will change, just like lots of other things have changed and become standardized over time. So the hope is that you're doing really, really high quality research that can then be used to inform practice.
Thank you.
Sure, thanks.
Oh yeah, I got a question from Zoom,
Okay.
from someone named Tyler, who asks if recommendations substantially differed between general public of the race in concern and academic philosophers who also identify the race in concern, who should be given more weight in that conversation?
Well, I don't think academic philosophers typically get the final say on just about anything. So I don't know. We don't have a. I think the role of communities. In the end, I think what we need to do is not see this as like adversarial, right? The whole point of positive, sort of constructive community engagement is that all of these voices are a piece of this, and you try to kind of understand, okay, where are the sources of disagreement, which sometimes lie in really different values or priorities or goals. Sometimes they lie in different understandings of information. So it's not that I think you should say it's us or them and it's like we put it up to a vote. I think we've got to understand and get really good at appreciating whenever anybody is raising concerns, what do we learn from that? And ensuring that community members, stakeholders of all kinds, not just sort of the lay public, but transplant professionals, transplant programs get evaluated on their outcomes. They have a real stake in this too, that all of these parties need to be at the table, because otherwise you miss important concerns that I think downstream lead to bad effects. But I don't know, my experience is not that people come to the academic philosophers and say, please tell us what to do.
Yes, I was wondering what, suppose I test positive for both mutations. Is there anything actionable that comes out of that? And I ask because, like with the BRCA mutations,
Right.
like part of what makes them so ethically hard is that you have a series of really tough life decisions if you test positive.
Yeah, that's a great question. And I'm not a clinician, so let's remember this. To the best of my knowledge, right now, the answer is no. I could imagine somebody saying maybe you yourself might decide, hey, I've got these two risk variants. I'm going to take extra good care of my health, right? So sometimes people, and this is not just genetic testing for kidney, related to kidney stuff, but some people say, once I learned that I was at increased risk for cardiovascular disease, I took better care of my cardiovascular health. So it's possible that some people it would be actionable in that sense. I don't know of anything that currently is medically actionable. I do know there is ongoing research to figure out if there are things that could be done. Is there a medication people could take? Is there a diet people need to follow? Is there some sort of more aggressive monitoring that needs to be done? So there's research going on to answer that question. But as of right now, I'm not aware of anything other than sort of people individually saying, I'm going to be ever more vigilant about my kidney health.
Currently, the sort of marketplace for organs is heavily restricted, right? It's not a free market. Do you think that, I don't know that it should be, but do you think if there were some more principles from using supply and demand, such as, someone who could sell an organ, do you think that would obviate some of the ethical issues or make them worse, or kind of like seller beware of I don't know if it's sort of related to how plasma is sort of done today, but do you think that would obviate some of these things or make them worse?
I'm not sure. I don't know how that would kind of have an effect on this, but I do think we have learned that there are people who are willing to accept what are called expanded criteria or extended criteria organs. So organs that are considered sort of not the best quality, but still transplantable. And there are people who accept those organs and surgeons who are willing to transplant them. So, and that's not just kidneys, it's been done with other organs as well. And so the idea of kind of, recipient beware, or just buyer beware, if you were in sort of a seller's market kind of situation, we have experience with that, not with sellers, but with recipients and surgeons who are willing to take expanded criteria kidneys. There was a paper a few years ago comparing the discard rate of kidneys in the United States versus I think may have been France. It may have been broader than France. The details escape me right now, but essentially they looked at what we would in the United States do with kidneys that met certain criteria and what was happening with these kidneys in other countries. And we discard kidneys at a much higher rate than these other countries. And so people started saying, if it's good enough for these other places and they're having good outcomes, why are we discarding so many kidneys? So even there was already kind of this wake up to, are we being too strict? And so I think all of that is a piece of this. It will be interesting if we end up with evidence that suggests, yes, there is this impact of the genotype on outcomes. Is that the kind of thing? Would that be considered an extended criteria kidney, or would it be considered a kidney that's not suitable for transplantation? Also goes that back to Gordon Hall's question, which is, what if you could prevent this, right? What if knowing the genotype meant you could prevent it? Does that mean you can then transplant the kidney and prevent kidney disease, the risk of kidney disease? all of those are big questions, right? We don't know the answer. But would people be willing to accept kidneys that are considered higher risk kidneys? I think probably so in some contexts, because people already do that with other kinds of increased, lower, what are considered lower quality organs.
All right, any other questions? All right, well, we have at this point kept Anna a bit past time, so why don't you join me in thanking her?
Thank you. Thank you so much for having me answer your questions.
Thank you, and we hope to see everybody, the camera's now facing me. We hope to see everybody again soon, and yeah, that's that.
Great, thank you.